Welcome back to the deep dive. Our whole mission here is to take massive, really complex source material and just make it crystal clear, make it actionable knowledge for you.
Exactly.
And today we're tackling a true foundational text. This is a comprehensive look at the core concepts from the Manual of Clinical Oncology.
It really is.
So if you're a medical expert, maybe a content creator, or just need a fast but really thorough update on the oncology world, this is for you.
And that thoroughness is so important, especially when you look at the history of this book. It actually started in 1983 as the Manual of Bedside Oncology.
Oh, wow.
Yeah. And the founding editor, Dr. Casiato, he always pushed for this duality. It was about top-tier clinical expertise, but also, and this is his phrase, the humanistic aspects of medicine.
I love that. Okay, so let's unpack this, starting right at the foundation. Cancer biology. Tumors, they're just masters of manipulating their environment, right?
They are. They essentially coerce the normal tissues around them into producing the growth factors they need to survive.
And just as important as getting things to grow is, well, ignoring the stop signs.
Exactly. Evading the checks and balances. We talk about tumor suppressor proteins like RB. But what's really fascinating, and the manual points this out, is that losing the function of just a single suppressor protein is almost never enough to cause cancer.
So it's a cascade of failures.
It's the multi-hit hypothesis in action. It takes a whole series of things to go wrong.
And they're also masters of avoiding cell death. We hear about apoptosis, but they manipulate other pathways too, like autophagy.
Right, which is the cell's natural recycling process. Under stress, a cell starts to scavenge its own parts for nutrients.
And cancer cells just hijack that.
They hijack it completely. It's regulated by the PI3 kinase, AKT, and MTR pathway, along with Beclin-1, and it lets them survive right when they should be dying.
And what about the opposite, necrosis? That seems so much messier.
It is messy. With necrosis, the cells swell up and burst, and they release all these pro-inflammatory cytokines. But here's the insidious part. Cancer exploits that inflammation. It uses the chaos to create a pro-neoplastic environment that actually stimulates more blood vessel growth and more tumor growth. It feeds on the destruction.
That brings us to a classic target, the cell cycle. For anyone learning this, it's so critical to know which drugs hit which phase. Can you map that out for us?
Of course. So if we look at the G2 phase, that's after DNA synthesis is done, the cell is making precursors for the mitotic spindle.
Okay.
And that makes it a perfect target for drugs like bleomycin and some of the plant alkaloids.
And then you move into the M phase, mitosis, where the genetic material is actually being pulled apart.
Correct. The M phase is a bottleneck, and that's where many of those same plant alkaloids do their best work by interfering with that spindle apparatus. Understanding that is key to building smart combination therapies.
Right, because you can hit different parts of the cycle at once. But the cancer cell isn't alone. Let's talk about the tumor microenvironment.
So important. The tumor relies on this reciprocal interaction with fibroblasts, immune cells, all these supportive cells. It's absolutely essential for tumor genesis.
And inside that environment, we have the idea of cancer stem cells, or CSCs. It's a bit controversial, right?
It is. They're a tiny fraction of the tumor, but they have these really troubling characteristics. They can self-renew, and crucially, they are often resistant to our standard therapies.
Which would make them the source for tumor recurrence or that long-term dormancy that we see.
That's the hypothesis, precisely. And that reality, the fact that you manage a patient for years, always worried about recurrence, that brings us back to Dr. Casiato's point about humanism.
The stress on clinicians.
Immense. The pressure is enormous.
So let's talk about that. Professional practice and burnout. How do you balance the core principle of do no harm with the duty to advance science in clinical trials?
That tension is there every single day. It forces you into these incredibly nuanced decisions. You always have to weigh the benefit against the side effects.
And a small statistical benefit might not be worth it for the patient.
Exactly. A paper might report a 5% improvement in overall survival, which sounds great. But for one patient, that might be a miracle. For another, if it comes with severe toxicity, it's completely unacceptable.
And the system is feeling that strain. The manual cites some pretty high burnout rates among U.S. physicians.
Yeah, it does. It's fueled by long hours, bureaucracy, the switch to EHRs. It's a huge problem.
So what are the prevention techniques?
It has to be intentional. You have to prioritize a healthy lifestyle, build strong social support, and engage in mental training, cultivating clear thinking and just equanimity under pressure.
Okay, let's shift gears to diagnostics, which have just completely changed the game. Let's start with whole genome sequencing, WGS.
WGS gives you the most comprehensive picture. for sure. But the challenge in the clinic is that it often flags VUSS variants of unknown significance.
So you get too much data.
You get a flood of data,
Mm-hmm.
and it's really hard to tell what's a truly pathogenic actionable mutation versus what's just, noise.
And that's why the more practical clinical gene expression tests are so valuable, like the 21 gene recurrence score, Oncotype
A
DX.
perfect example. It's used in breast, colon, prostate cancer, not just for data,
Yeah.
but to predict which patients will actually benefit from adjuvant chemo. It cuts right through that VUS problem.
And this molecular precision has totally redefined clinical trials. We have basket trials now.
Right, where you take a single targeted drug and test it across lots of different cancer types that all share the same mutation.
And the flip side of that is the umbrella trial.
Where you take one cancer type and test a bunch of different drugs against the different mutations found within that cancer. The NCI-MADCH trial is a huge example of that.
It's a fundamental shift. Okay, let's move to imaging, nuclear medicine.
So here we're talking about functional metabolic data. We use gamma cameras. They have a sodium iodide crystal that's coupled to photomultiplier tubes.
And the collimators are basically lead lenses, right? They focus the radiation from things like technetium-99 meter, but the resolution is about 1 centimeter.
It is, which is good. But then you have 18 FDG PET scans, the metabolic gold standard. And for that, the procedure is everything.
The patient has to be fasting.
Fasting and, this is critical, euglycemic. Their blood glucose has to be under 200 milli-GDL, or the tracer just won't distribute correctly.
And for interpreting, say, a primary brain tumor.
You're looking for hyperactivity. The rule of thumb is a ratio. The tumor needs to show 1.4 times the FDG concentration compared to the normal white matter on the other side.
And nuclear medicine isn't just for imaging anymore, it's therapy.
Targeted radionuclide therapy. A great example is radium-223 chloride for castration-resistant prostate cancer. The principle is just elegant. It emits short-distance alpha particles.
So it only kills cells that are very close by.
Exactly. It targets the cancer cells right next to the bone cortex, which spares the normal bone marrow. It's brilliant, but the patient has to have bone-predominant disease and good blood counts.
Now, for external beam radiation, or RT, the basis is the target cell hypothesis, right? The radiation has to hit critical targets in the nucleus.
Correct. And the cell survival curve has that classic curvy shoulder at low doses, which reflects this two-component theory of cell death and repair.
And we have really sophisticated dosing strategies to exploit that, like hyperfractionation.
Hyperfractionation uses a smaller dose per treatment, but more treatments. So you get a higher total dose in the same amount of time. The goal is to enhance tumor killing while keeping late tissue damage acceptable.
And then there's accelerated fractionation.
Which is all about shortening the overall treatment time to overcome the fact that cancer cells can start to repopulate faster during a long course of treatment.
But the goal for both is the same.
The goal is always the same. Separate the tumor control probability curve from the normal tissue complication probability curve. That gap between them, that's your therapeutic window.
Let's move to systemic therapies. A couple of the classic chemotherapy agents, cisplatin, what do we need to remember?
It's a heavy metal that alkylates DNA, forming these platinum crosslinks. And clinically, you have to remember its plasma half-life is long, up to 3 days.
And what about when it stops working? Resistance.
Acquired resistance is often because the cancer cell literally alters its transmembrane transport. It learned how to pump the drug out.
Okay. And then there's capecitabine, the oral prodrug. Very convenient, but it has some very specific toxicities.
And patient counseling is absolutely essential here. Diarrhea and hand-foot syndrome, that palmar plantar erythrodysesthesia, are the big ones. We see them in a huge range, from 15% to 50% of patients.
That's a huge range. So from there, we have to talk about the immunotherapy revolution. This changed everything.
It really did. And it all comes down to regulating T cells. For a T cell to activate, it needs two signals. The T cell receptor has to recognize the antigen.
And it needs that costimulatory signal, like CD28 binding to B7.
Exactly. But the body has brakes to prevent autoimmunity. Those are the inhibitory checkpoints like CTLA4 and PD-1.
And the drugs just block those checkpoints. They release the brakes.
That's it. And the clinical impact was profound. Ipilimumab, the CTLA4 blocker, approved in 2011, showed a durable response in about 15% of advanced melanoma patients at 5 years. That was unheard of.
But releasing the brakes comes at a price, immune-related adverse events, or IRAEs.
And clinicians have to know how to spot them. On the skin, you look for vitiligo or a rash. In the GI tract, it could be severe diarrhea, even a colitis that looks just like Crohn's disease.
Okay, let's pivot to palliative and supportive care, opioid management. Can you give us a practical example of how to dose?
Sure. You always start with short-acting opioids to figure out the total daily requirement.
So let's say a patient needs a total of 75 milligrams over 24 hours. What's next?
You convert between 50 and 100% of that daily total to a long-acting formulation. Then the breakthrough dose is calculated as 10 to 20% of that total daily dose.
So for our 75 milligram patient, the breakthrough dose would be 7.5 to 15 milligrams.
Precisely. That precision is key. And a clinical pearl. Prophylaxis for opioid-induced constipation, usually with something like Senna, is mandatory for all patients on opioids.
Non-negotiable. Got it. And what about delirium?
First step, always, is to look for an underlying reversible cause. Infection, medication, kidney, or liver dysfunction. Always rule those out first. In a truly terminal patient, neuroleptics or benzos might be used for comfort.
These are such difficult conversations to have. The book mentions the spikes protocol.
Yes, for structuring those goals of care talks. And the most sensitive part is often the K, the knowledge stage, where you have to deliver the bad news.
And what's the advice there?
It's very practical. Avoid jargon. Pause often. And always give a warning shot. Say something like, I need to share something serious with you. It gives the patient a moment to brace themselves.
So important. And let's clarify the definition of hospice.
It's a philosophy of care for terminally ill patients, generally with a prognosis of 6 months or less. It's about comfort and quality of life. And most people don't realize that the majority of hospice care is delivered in the patient's own home.
Not in a facility. That's a key takeaway. Okay, let's wrap up with two major clinical areas. First, non-small cell lung cancer, or NSCLC.
Right. The epidemiology here has shifted our thinking. A huge portion of cases, 10 to 15% in the U.S. and over 30% in East Asia, are in people who have never smoked.
And those cancers are different.
Very different. They're often driven by specific mutations like EGFR or ALK translocations. This means for stage 4V disease, management is almost entirely dictated by molecular testing.
So platinum chemo is still an option.
It is, giving about 9 to 10 months median survival. But we have strict restrictions. Pemetrexed is only for non-squamous histology, and bevacizumab, the anti-VEGF drug, is strictly contraindicated in squamous cell due to the risk of fatal lung hemorrhage.
Wow. Okay, and finally, as our treatments get better, we have more cancer survivors.
A growing population that needs specialized care. Survivors are at higher risk for second cancers and all sorts of chronic conditions from their treatment.
And the tool for that is the Survivorship Care Plan, the SCP.
It is. It has to be delivered when they finish their main therapy. It needs to detail potential late effects, the cancer surveillance schedule, and address psychosocial effects like fatigue, PTSD, anxiety, which are very common.
It's a roadmap for the rest of their life.
It has to be.
We've covered so much ground today, from, the subcellular biology all the way to the most compassionate, humanistic communication skills needed for palliative care.
It really shows that modern oncology demands both, that molecular rigor and an equally high degree of humanistic practice.
Absolutely.
The field changes so fast, we have to constantly strive to learn. All this foundational knowledge is only valuable if it's applied with the patient's holistic well-being right at the forefront.
A perfect place to end. To reinforce everything you've learned in this deep dive, we want to leave you with a final thought exercise based directly on the source material.
Okay, here it is.
A 65-year-old patient has just been diagnosed with non-squamous stage IV NSCLC and is ready to start systemic treatment. Based on what we reviewed, name 2 specific molecular targets or markers that would influence the choice between a pemetrexed platinum regimen, crizotinib, or bevacizumab. And for the second part, explain the key contraindication for one of those 3 therapies, justifying the specific histology where it is absolutely forbidden.